mẹ́rìndínlógún tì mọ́lé.
Correct, mo gbọ́ yẹn náà.
Wọ́n sì
ex-governor kan wà láàrin wọn. Kí lẹ pé wọ́n ní pé ex-governor kan wà láàrin wọn.
Ebi bẹ́ẹ̀ mi náà ṣe gbọ́ nìyẹn. Wọ́n wá nígbà tí wọ́n wá béèrè lọ́wọ́ bọ̀dá Bímbọ́lá, wọ́n ní àwọn kan ní iléeṣẹ́ ìjọba ń sọ pé àwọn tí wọ́n promote ni wọ́n fi sátìmọ́lé nígbà tí wọ́n jọba ọ̀mọ́rọ́ tí wọ́n pa. Ó ṣe jẹ́ pé torí pé wọn ò promote èèyàn ni wọ́n wàá fi sátìmọ́lé, bó ló ṣe jọra wọn.
Kò jọ.
Ṣùgbọ́n èmi rò pé kò yẹ kán fìyẹn parọ́, kò yẹ kán parọ́ kán bò wọ́n. Àwí pé wọ́n fẹ́ gba ìjọba wọ́n sì rí wọn mú. Èmi rò pé iyì fún Tinubu. So kí wá ni wọ́n mọ̀ parọ́ sí?
Ó ti mọ́ ọ lára ni.
Bóyá wọ́n rò pé àwọn tí ò fẹ́ràn wọn á máa sọ pé ṣe bá sọ fún yín pé ọwọ́ fẹ́ báyìí.
Ò rí gbà.
Wọ́n á máa sọ pé wọ́n máa fi lérí fún wọn pé ọwọ́ fẹ́ báyìí náà. Gbogbo tó ń ṣe mọ́nì ẹ̀tàn ṣe ń fi ṣe bòńkẹ́lẹ́.
Wọ́n ní ẹnìkan tó súnmọ́ ẹgbẹ́ APC dáadáa, wọ́n ní àbúrò rẹ̀ wà ń bẹ̀. Wọ́n ní ológun ni àbúrò ẹ̀, wọ́n ló wà ń bẹ̀. Ẹnjìníà jẹ̀wò ó ṣẹ̀ṣẹ̀ wọlé, gbogbo wa la rí ẹ o láìfù ní 325. O ṣé o, adúpẹ́ o.
3 minutes ago.
Ṣé ẹ jẹ́ kí ẹnjìníà mọ̀ wípé àwọn èèyàn kò lè tí bẹ̀rẹ̀ until the next hour.
Ó tiẹ̀ ti láìpù òun gangan pẹ̀, táìmù tiwa ní òlò kò ní lo táìmù tiwọn, àwa la máa sọ fún pé kò yẹ kó tí ì wọlé, ṣùgbọ́n òun gangan ó lé 9 ó kúrò ní 80. Tí ò bá sí àyípadà níbi tẹ́ ẹ sọ yẹn, ó mì pé a ní rìkọ́ọ̀dù láti 25 minutes ago.
Bẹ́ẹ̀ni.
So ó ṣe o ẹnjìníà, a máa tún sọ Yorùbá Gbode is not like that. And I've warned you several times. So anyway, ìpàdé di ẹ̀yìn kínní, ó dẹ̀yìn ìsìn.
Bàbá Oyèfúnlẹ̀, ṣé ọyẹ́ ló mú báyà bí ooru ní Naija?
No, very nice weather ni o, fan mi tí ẹ̀ tó air conditioner. Fan kékeré ló kàn. Nice beautiful weather mi rírú ẹ̀ rí.
That's good.
Ṣé nítorí náà ẹ ṣáà ti múlé lọ́wọ́ báyìí? Abẹ́ ń padà.
A máa rí 2027.
Wow.
Bọ̀dá bí.
How are you doing? Nàìjíríà tó máa bọ̀.
Lo English Trump.
Ìjọ ọdún kan láti resolve Nàìjíríà tó máa bọ̀ ńgbà yẹn.
Ẹ máa ṣe wọn jàre.
Beautiful bill.
Bàbá òṣèlú ló ṣe ẹ̀pẹ̀ ní o.
Ẹgbẹ́ Trump wọlé tán wá sá kúrò.
Wá sá lọ sí Nàìjíríà.
Ṣé bó ṣe yẹ nìyẹn?
Kò máa yẹ bẹ́ẹ̀. Ọ̀túnba òṣèlú ló pè é sí yìí o. Wọ́n ní wọ́n ti change aago wọn sí. Wọ́n flip back spring forward rather.
So 2:30 ni wọ́n wà báyìí.
Bẹ́ẹ̀ni wọ́n làwọn máa wọlé láìpẹ́ sí.
Ẹjẹ́ àmọ́
gbàfàbí wa lọ.
Bẹ́ẹ̀ni ẹ ṣe.
Ká máa tàkúrọ̀sọ ní Yorùbá ń pè.
Bẹ́ẹ̀ni kí wàá ní Ìjẹ̀bú ń pè.
Prince Kalejaye wàá ní Ìjẹ̀bú tí ń pè.
Tí Yorùbá lè sọ yẹn, èwo ni bóòlù ṣe ń pè.
Prince Kalejaye kẹ́tọ́ béèrè lọ́wọ́ èmi Prince Kalejaye á dá wa lóhùn pé báwo ni Ìjẹ̀bú tí ń pè. Àwọn ọ̀daràn.
Mo ní ẹgbẹ́ Trump wọlé tán ẹ wá sá kúrò ńlù. Ṣé bó ṣe kẹ́ ṣe nìyẹn o?
Báyé ti rí nìyẹn o.
Bó ṣe kẹ́ ṣe nìyẹn. Ẹ wá fi bàbá nìkan sílẹ̀. Kán máa bá tó Trump.
Bàbá Adébóyè nìkan àwọn nìkan.
Ó ti yẹ kó lé máa yẹn mẹ́. I don't know why.
Ta ló fẹ́ lè?
Ó lògùn fún wọn ni.
Ta ló fẹ́ lè? Kò sẹ́ni tó máa lè.
Gbogbo nǹkan tó ń ṣe ló mú jẹ náà.
Àwọn ló fi bẹ́ẹ̀, àwọn tó fi bẹ́ẹ̀ ò lè lè.
Bẹ́ẹ̀ ni. Ohun tó dà ń ṣe ó dùn mọ́ wọn.
That's right. Until tó bá kàn wọ́n o. Tó bá kàn wọ́n àwọn náà pariwo. But right now.
Wọ́n á pariwo apẹ́kun tó lè confess pé àwọn ṣàṣìṣe.
Wọ́n ti confess.
Wọn kì í fẹ́ tètè ẹ wo àwọn beef farmers ń sè. Torí pé ó fi tariff lé everything, owó beef ga sókè. So àwọn make owó. Ìgbà táwọn aráàlú wá ń pariwo, ó wá sọ pé òkè òun á lọ kó beef láti Argentina. Pé láti fi flood market. So beef farmers wá sọ pé irọ́ o. Beef láti Argentina báwo? Àwa tá a dìbò fún ẹni yìí. And I think he's going to do that.
Ó sì lóun ò fẹ́ bá Canada sọ̀rọ̀ mọ́ pàápàá.
Bẹ́ẹ̀ ni, iṣẹ́ ìbára ẹ̀ kò tọ́.
Nítorí Reagan nǹkan tí Reagan sọ.
Ara rẹ̀ kọ òtítọ́ kò sí rọ́nù tán fídíò tán play but being the kind of person tó ń jẹ́.
Exactly. Ìgbéraga yẹn ti pọ̀ jù mọ́. It's too much.
Níbi tó lọ yẹ o, tó bá rí pé àwọn tó wà ń bẹ̀, tó bá rí pé wọ́n káràmásìkí òun ṣe ló máa padà wálé kíákíá. Ṣe rántí pé ó ṣe bẹ́ẹ̀ nígbà tó wá sí Canada. Tó bá ti lọ síbì kan tó rí pé àwọn yẹn ò fẹ́ máa bọ̀wọ̀ fún òun, àfẹ́ máa jíṣòro ẹ̀ á lóun ní meeting nílé.
That's right. Wọ́n sọ àǹsí nǹkan tí ẹ sọ tí àwọn nǹkan dẹ̀ ni pé until tó bá go against MAGA wọ́n á sì máa support ẹ̀. Ǹjẹ́ ẹ gbọ́ pé MAGA demonstrate against Patel of the FBI?
Oh yeah.
Ǹjẹ́ ẹ gbọ́ yẹn?
Gbọ́pọ́n demonstrate wọ́n sọ̀rọ̀ bá lórí X.
Wọ́n sọ pé we are taking our country back. Pé kí Patel
padà lọ sí India. Bẹ́ẹ̀ ni wọ́n sọ pé kì í ṣara wọn. Kí ló dẹ̀ fà á ní wípé ó give message ó send message nígbà Diwali anniversary celebration tó fi ń wish àwọn èèyàn that celebration of light. Ó send the message tó fi ń wish àwọn èèyàn well. Làwọn á sọ pé that's a foreign religion. Pé who are you? Ó nìkan kọ́. Ramaswamy náà nǹkan ṣe bẹ́ẹ̀ rántí ẹ̀. That man in Ohio. Ṣé rántí?
Ṣé ó fi ṣe chief of staff àbí kí ló fi yẹn kò fún ní nǹkan kan?
No, kò fi ṣe anything. Ṣé o pé yẹn òun àti Moss náà dìjọ bẹ̀rẹ̀ Dodge.
But ìyẹn support ẹ̀ náà, ìyẹn support ẹ̀.
Ó ń support ẹ̀ but ó wá fẹ́ lọ ṣe governor ní Ohio. So àwọn ará Ohio wá sọ pé no kì í ṣara wọn torí India ni.
Kò ní lọ sí Indian state.
Wọ́n ní kì í ṣe ara wọn pé kí ló ń wá pé báwo ni ó ṣe lè wá ṣe governor ni. So àti ìmọ̀ bí gubernatorial pursuit ẹ̀ bó ṣe máa lọ NDC.
Mo kí gbogbo ilé o.
Káàsán.
Ẹ káàbọ̀.
Yes sir.
Ẹ káàbọ̀ ẹ sọ fún wa pé aago ti change.
Ẹ̀wọ̀n tó fà gan nìyẹn.
Aago tí change Láwórì o.
Àwọn bàbá
ṣaago tí ẹ wà Láwórì ni.
Àwọn bàbá dókítà ọlọ́pọlọ náà jí mi.
Àníṣaago wà Láwórì.
Àwa la kọ́ bẹ̀rẹ̀ aago bàbá. Lẹ́yìn àwa la kọ́ bẹ̀ sí trace distance Badagry sí area àtọ́kọ́ nǹkan àwa la kọ́ bẹ̀rẹ̀ aago.
Ó dáa mo ti gbà.
Ètò fi òjìji ọ̀pẹ wọ́n fi ń wò.
Anyway, kẹ́ni kankan má bù mí láti Jẹ̀bú o.
A fi ń ṣe àpèjúwe ni.
Ẹ jẹ́ ká ṣé olóòtú ṣé wọ́n ti dé ẹ jẹ́ kí n fóònù Báṣẹ̀gùn àti guest wa tó ń bọ̀ lálẹ́.
Má jẹ́ ká ní ìsásá dídì. Ẹ jẹ́ ká máa tàkúrọ̀sọ ká máa lé wọn láré. Ọ̀pọ̀lọpọ̀ àwọn èèyàn náà.
Torí time to change yẹn ó yẹ máa affect olówó náà ló máa affect tálíkà.
Àti ẹ̀gbọ́n ẹ̀yin olówó.
èmi tẹ rò pé
ìfẹ́ẹ̀tì
àwọn
wo ló
olówó
yẹ kó
nìkan
tún ní lára àwa tálíkà
èmi rò pé olówó nìkan ló
àwa
ó
tálíkà
change
ẹrú
fún ni
Ọlọ́run.
kò change fún rìtáyárì kò níbi ire àbírọ́ mo pa
ṣé mo ẹ̀yin kankan mọ̀ ń pẹ́ ni tó fà á nìyẹn.
èmi ò níbi ire ọba change ẹ̀ wákàtí méjì síwájú sẹ́yìn kí ló kàn mí ìgbà tí n bá sùn ni ìgbà tí n bá dẹ̀ jí ni kọ́lọ̀ ń jí wa rí.
àmì
That's
o
all.
Àmín.
That's
ẹ ṣé
all.
bàbá
èmi náà fẹ́ dàbí tiyín.
ẹnìkan
ẹ ṣé bàbá
pè mí lánàá
ẹ ǹlẹ́ o
wọ́n ní GDP Nàìjíríà ó ti ń ṣe kíkan mo ní táwọn máa measure ẹ̀ mo ní mo pòsì ọmọ kan tí ilé wọn sí UCH mi rò pé ó tó 3 minutes walk. ọmọ yẹn ó ní àrùn kan bóyá liver problem ni ọmọ 23 years ó yẹ kó ní camp ni inú ẹ̀ wá dàbí oyún oṣù mẹ́jọ wọ́n dábàá ṣe máa dá 30 million fún ọmọ yẹn láti gbé ọmọ yẹn mo á bẹ̀ sí sunkún ní àná àbíjẹta mo ní so GDP mo yà pé tiger mo yí pé inú pépà lẹ ti ń ṣe GDP eléyìí ò ń ṣe tó ń pè mí ní ìlú kọ̀ọ̀kan òṣòrìrè tí ò bá ní education àti minimum healthcare mo ní kò possible.
No, Sherry, the way GDP tó ń sọ lọ́rọ̀ wa ní Nàìjíríà tẹ bá ń gbọ́ news Nàìjíríà ẹ rí i pé wọ́n sọ pé wọ́n change àwọn basis for those calculations or for those analysis some months ago. Àwọn Wálé Ẹdùn and co wọ́n change basis tán fi arrive at those numbers. So ìyẹn ló wá jẹ́ kí gbogbo ẹ̀ máa wà so favourable. And well, even as favourable as it is, could translate dé ọ̀dọ̀ àwọn common people.
Of course,
common man on the street.
It's not that pé kò sí homeless over 100,000 ní California now, but tẹ́wá yìí máa tìrìkọ́tà American citizen tìrìkọ́tà àwọn tó ń gba America at least wọ́n ṣì wà above poverty level ordinary people. Àwa ti wá wà below poverty level àwa below poverty kìíní so irú GDP Iran wo náà fi ń wo calculation irú gègé ò lẹ́nu kọ́ sórí.
irọ́ náà ń pa lọ́wọ́ irọ́ náà ń pa.
GDP tí ó tẹ make sense.
bóyá wọ́n fẹ́ sọ Yorùbá wọn ò mọ̀ sọ ni. wọ́n pè ní wọ́n lè ẹni tí bá ń ti Yaba lọ sí Agídìngbí ó lè jẹ́ pé nǹkan tó ń sọ táwa pè ní GDP.
bóyá jìbìtì náà dẹ̀ ń sọ bàbá bóyá jìbìtì náà
ó sì ló lè jẹ́ bẹ́ẹ̀ ó lè jẹ́ jìbìtì ó sì lè jẹ́ Agídìngbí.
mo dáyé pé package
wọ́n sọ GDP.
ẹ tó yẹ pé package láti tún fi gbowó mi láti tún fi bọ́ọ̀lù lẹ́ ń ṣe ìyẹn is not clear to the ordinary people because gbogbo àwọn paperwork tẹ̀ ń ṣe yẹn gbogbo paperwork tẹ̀ ń ṣe ẹ wá lọ fi hàn IMF pé kẹlẹ̀ tún rówó gbà ní GDP àwọn tó wà ní lesion tó wà ní mi ìtẹ̀wé dárúkọ àdúgbò àwọn ọ̀rẹ́ mi.
àwọn oníṣòkòtò tó ń tírín.
kájẹ láwọn tó wà ní mi ìfẹ́ dárúkọ ìlú kankan torí mi láti ṣọ́ra.
ẹ dárúkọ Ìbàdàn lẹ fẹ́ sọ Ìbàdàn lẹ fẹ́ sọ Ìbàdàn lẹ fẹ́ sọ.
Professor Adébóyè a máa ń gbé crack of yìí. Professor Adébóyè aláwọn oníṣòkòtò tó tírín.
àwọn oníṣòkòtò tírín tí fi kí mú.
fi kí mú fẹ́ èbó.
mo ní tẹ́ ẹ̀ bá tí ì lọ sí Òjòkòrò kẹ́ lọ sí èrè àbíkan ní Ọ̀tà Ajílétí àtàn Ọ̀tà ọ̀nà sẹ́yìn kẹ́ lọ sí Bàdágìrì kẹ́ lọ sí Ìpókíà kẹ́ lọ mẹ́jọ ṣé wọ́n wà nílé ayé àbá wà lọ́rùn àbọ̀ fẹ́ kú ni ẹni compare GDP kò make sense.
no tẹ bá wò gan wá ní inflation numbers ó lọlẹ̀ I mean inflation numbers ó lẹ̀ bẹ́ẹ̀ àwọn èèyàn mélòó ló lè jẹ oúnjẹ ẹ̀mẹ́ta lójúmọ́.
Paperwork ní gbogbo tán wí yẹn
mẹ́ta ẹlòmíì tí oúnjẹ kan lójúmọ́ oúnjẹ kan.
kájẹ ní gbọ̀ngàn kájẹ láwọn àwọn tó wà ní gbọ̀ngàn tàbí àwọn tó wà ní Jẹ̀bú.
àwọn tó wà ní gbọ̀ngàn torí pé wọ́n ń dáko àwọn ń jẹun ẹ̀ẹ̀mejì àwọn tó wà ń Ìbàdàn tí ò nílẹ̀ láti dáko ẹ̀ẹ̀kan so bá ṣe bírèkì ẹ̀ lọ Nàìjíríà nìyẹn.
Good news o, Ìbàdàn state ti go through second reading o. So ọmọ máa kọ kò ní gbàdá ní kí n kú ewu ọmọ o. So Ìbàdàn àti Ìjẹ̀bú àwọn Ìjẹ̀bú tó wà láàrin wa kan bẹ́ẹ̀ sì máa wá bọ́n ṣe máa lọ́lé o.
Ẹ máa lé wọn ní.
Àwọn tó wà lé kọ́.
Àwọn tó wà lé tó lè ṣe.
Hurricane dẹ̀ wà ní Dominican Republic right now.
Ṣé pé Ọ̀túnba náà kò lè yan fanda káàkiri mọ́?
I did say that.
Ayé òsì ń lè wá ní Àwórì state náà yẹ kó.
Àwórì state. Wàhálà bẹ́ẹ̀.
Káyọ̀ kò ní Ògùn state.
A ní gbọ̀ngàn state náà lè tẹ̀ ń bá a bọ̀ yìí.
Gbọ̀ngàn ni lẹ́yìn
Gbọ̀ngàn ẹ lè ní gbọ̀ngàn state lórí gbogbo.
Kí ló dé?
Gbọ̀ngàn empire ni gbogbo wa wà. Ilé ẹ̀dẹ̀ create state tó bá wù yín. Gbogbo ẹ̀ gbọ̀ngàn empire ni.
I'm a create Akriboto.
Okay, ẹ̀dẹ̀ create Akriboto state. But as Akriboto state ni o. Àti Ìbàdàn state ni o. Àti Àwórì state ni o. Gbogbo pátápátá tó fi dé Benin. Gbọ̀ngàn empire.
Yes.
So,
Professor Adeboye.
Ẹ jẹ́ kí n fóònù.
Ní ọjọ́ mẹ́jọ
Ẹ jẹ́ kí n fóònù.
Ọ̀túnba.
Yes sir.
Yes ma.
Máa ń fi yes sir ń gbà mí máa ń lò fún wọn.
Olóòtú.
Kí lẹ fẹ́ sọ ma?
Olóòtú, ká tó bẹ̀rẹ̀ ẹ wá nǹkan ṣe sí device yín o. Ó dàbí pé òun yín hálẹ̀ kọ̀ọ̀kan.
Ó dẹ̀ sọ fún àbúrò mi kán má ra ti Ìjẹ̀bú ńjọ́ yẹn o. Kán má ra ti
Ó sì wọ́n kọ́ máa tún ti Ìjẹ̀bú.
Ẹni kí n má ra ti Ìjẹ̀bú.
Ó ṣe ń dún yìí. Àgbọ́rọ̀ yín o. Bóyá kẹ́ change ẹ̀ sí ti Àwórì.
Bóyá wọ́n wà Naija.
Wọ́n
wà Naija àbí.
Àgbọ̀ yín o. Àdìtẹ̀ mu wáìnì.
Ọ̀túnba Ọlábọ̀ ní gbogbo àwọn àdìrẹ tẹ̀ ń wọ̀ yẹn. Èmi kọ́.
Ṣé à ń gbọ́ mi báyìí?
Ẹ wo.
À ń gbọ́ yín nísìnyí. À ń gbọ́ yín báyìí. Tẹ́ sọ ya gbọ́.
Nǹkan tó dáa ṣẹ́rí bẹ́ẹ̀ ṣe sọ yẹn. Màá dẹ̀ make arrangement kíkan dọ́dọ̀ yín torí bíbi títí gbà tí má sọ títí gbà fún yín báyìí ẹ̀yin gangan máa sára ẹ máa fún mi ní sára pé mo mọ ibi tó dáa láti gba nǹkan màá arrange nǹkan fún yín kò dẹ̀ ní jìnnà sí yín.
Ọ̀dà ẹ ṣeun.
Nǹkan tí mo ní ọjọ́ mẹ́jọ ẹ dákun ẹni tó mọ̀ nípa ètò ìṣúná ètò ìnáwó káràkátà ní ọjọ́ mẹ́jọ a fẹ́ kó ìgbìmọ̀ jọ tá a máa sọ̀rọ̀ lórí bóyá ilé tó lọ àwọn òkòwò wo ló ṣeé ṣe nílé àwọn tó lọ ṣòkòwò níbo ni wọ́n bá dé lásán ní ọjọ́ mẹ́jọ pẹ̀lú ògo Ọlọ́run.
Ìyẹn dẹ̀ da torí bàbá wà nílé bàbá Oyèfúnlẹ̀ wà nílé àwọn ríran wọ́n rílẹ̀ so bóyá wọ́n lè fún wa ní àwọn bóyá ideas àbí nǹkan nípa ohun tó ń lọ nílé.
Bàbá Adébóyè ìgbà ọ̀la máa confam ambassadorial kíní wọn ò tó wọ́n ti sọ pé wọ́n ti accept o pé àwọn kúkú máa wà lẹ́kọ̀ọ́.
Ta ni yẹn? Fáàrí mi ò kọjá Ọ̀tà.
Bàbá dókítà ọlọ́pọlọ ti agree pé àwọn wà lẹ́kọ̀ọ́ as ambassador Yorùbá Gbòde àwọn àbẹ̀ tí àwọn àti second election so àwọn wà níbẹ̀ nísìnyí so bẹ̀tọ́ ní àwọn need approval. Dókítà Oyèfúnlẹ̀.
Ambassador Fálétí ńkọ́?
Fálétí. Mi ò mọ̀ pé Fálétí wà lórí.
No, wọ́n sì bí wọ́n wà ní Yorùbá Nation tẹ́lẹ̀.
Chicago náà máa wà.
Fálétí Èkó tún nù o.
Yorùbá Nation then ambassador ni wọ́n sìn UN.
Chicago wà lóde.
Fálétí ti
Yeah,
ní tiwọn.
Chicago. Yeah, Chicago ni.
Ọmọ
Chicago.
ìlú bo ni wọ́n láti Nàìjà.
Mo state ọtí wa.
Torí Fálétí kan náà là wá mọ̀. Ọ̀yọ́ ni o. Ọ̀yọ́ ni sẹ́.
Àwọn náà ni.
Bàbá Fálétí.
Ṣé wọ́n tan mọ́ bàbá Fálétí ni?
Àbúrò ọmọ náà jẹ́.
Ọmọ Fálétí.
Bẹ́ẹ̀ ni.
Àwa mọ̀ pé bàbá bímọ tó dàgbà tó bá ń.
Ọmọ làbẹ́ pé ọmọ lẹ́gbọ̀n lábúrò ni.
Bàbá nìkan nìyá rẹ̀ àti bàbá rẹ̀ bí. Bàbá Fálétí.
Ṣàlàáfíà ni o. A ti wọlé.
Olótù.
Ó náà wà yẹn
Sà.
capture yín náà o.
Mo bá ọmọ kan lọ sí school ní Ìbàdàn ní Government College.
Yes, sir.
Fálétí lorúkọ ní last name ẹ̀ ní Òṣùrùpọ̀mọ̀ Ọ̀yọ́. Mi ò mọ̀ bóyá ọmọ Ọ̀yọ́ ni àbí bẹ́ẹ̀ kọ́. 1950s ni mo sọ yìí o.
Bá mi sọ fún dókítà kan jọ kan lọ́gàn. Bá mi send ẹ̀ sí wọn àbí.
Àwọn méjì ló wà ní Chicago.
Of course.
Yeah, ti Chicago yẹn ti wọ a máa wọ 17 sí.
Báyọ̀ Fálétí àti Stephen Fálétí.
Yeah, Steven, right?
How old is Steven?
Stephen will be about 71, 72.
No. Àwọn tẹ́mi sọ yìí about in my age group.
Ẹ̀gbọ́n ẹ̀ ní Báyọ̀. Ẹ̀gbọ́n yẹn bí about 76.
No, kò tẹ ẹni tó bá jẹ́ 76 ò lè bá mi ṣe àjọ lọ sí school.
No, it couldn't be. Ìyẹn ni mo ṣe ní bóyá ọmọlẹ́gbọ̀n láàbúrò ni wọ́n or something like that.
Yeah.
Fálétí náà làwọn.
But Stephen yẹn ti UN ni òun ambassador ni UN.
Okay, jẹ́ kí n tún sáré ọ̀sẹ̀.
Bàbá Fálétí wọ bàbá.
Wọ́n Fálétí tó ṣe ìwé wọ́n rò pé wèrè ni àbí.
Adébáyọ̀ Fálétí nìyẹn.
Incidentally tó wà Chicago yẹn náà Báyọ̀ Fálétí ni but ètò senior Báyọ̀ Fálétí.
But èyí tó wà ní Yorùbá Nation lèmi sọ tẹ́lẹ̀.
Yeah, àbúrò quiet guy but I think he studied accounting.
Yeah, very quiet.
He's a PhD guy,
Yeah.
Adébáyọ̀ Fálétí tí wọ́n rò pé wèrè ni.
Wọ́n rò pé wèrè ni yà.
Àwọn wọ́n wá ṣe kínní ní University of Ibadan 1964. So wọ́n kì í ṣẹgbẹ́rú àwa ẹ̀ rárá wọ́n jù wá lọ wọ́n lè jù wá nù kọ́lọ́ wọn fọ̀rùn kẹ́ wọn.
Mo rántí pé akàwé bàbá yẹn náà in the 60s. So.
Yeah. Ó ti rìn jìnnà kó tó lọ sí yunifásitì ó kàn jẹ́ ó lọ ka ó fẹ́ fi was a fine man, fine gentleman. Ó ní Adébóyè mo ní ó ní ìjọ ọmọ nǹkan táwọn ṣèkìrì ń pe ọlá mo ní mi ò mọ̀ ó lànà ni wọ́n ń pè mo ní àbáwo nìyẹn ṣe jẹ́ ó ní wọ́n gàn ni.
Don't reverse it.
We had fun. Oh, I don't even know how much of what he said was just for a joke or two, but he was a very nice guy. Ó dẹ̀ mú àwọn atájọ́ ọmọdé lẹ́yìn ẹ̀ ó treat wa dáadáa We are the foundation members of Azikiwe Hall. I will always remember him well.
That's right. The Yoruba Parakuni Shekirisha.
Yeah. But they must say anybody.
Okay. Say 50 more minutes. Lama expect guests to
mo ti tún pè wọ́n sí ẹ má bínú dà pé 1 hour difference ló fa.
Okay.
UK
UK làwọn wà.
UK bẹ́ẹ̀ mo ti wọ́n ti bá mi sọ̀rọ̀ nsìn.
Oh, beautiful.
They are forward. They are coming up now.
Wọ́n ní Ìjẹ̀bú tó pàdé Ìjẹ̀ṣà. Wọ́n á fẹ́ra wọn. Àwọn ló ń jẹ́
Ìjẹ̀bú-Jẹ̀ṣà.
Yes.
Wọ́n ní Ìjẹ̀bú tó tún wá pàdé àwọn kan ní tí wọ́n jẹ káàkiri. Àwọn ni wọ́n ń pè ní jẹ̀kírì.
That's a nice one.
Bóyá wọ́n pàdé àwọn ará Kiribọ́tọ́ ní ìṣọ́. Wọ́n ní jẹ̀kírì.
Oh God. Ìjẹ̀bú gbọ̀ngàn apó òsì.
Wẹ́ Akiribọ́tọ́ àti gbọ̀ngàn ò fi bẹ́ẹ̀ yàtọ̀ síra wọn.
Ọ̀nà kan ló kàn gba àárín wọn kọjá. Mo ní ọ̀nà ìmí gbọ̀ngàn ní ìlú tí ọ̀nà kọjá yẹn. Mo ní ọ̀nà yẹn ló la Kiribọ́tọ́ sí kúrò nínú gbọ̀ngàn.
Kí wọ́n tó la títì yẹn, títì míì tá a máa ń gbà was a mile, I mean, kò tiẹ̀ tó 1 mile. Títì ayé àtijọ́ tó lọ láti Ìbàdàn lọ sí Benin. Mile 37 Akiribọ́tọ́ ló wà.
Ìbàdàn lọ sí Benin. Okay.
Mile 37 Akiribọ́tọ́ ló wà. Mile 38 gbọ̀ngàn ló wà. So láàrin inú gbọ́ǹbẹ̀ yẹn torí máa lọ kí àwọn grandparents mi l'Akiribọ́tọ́ àti padà lọ sí gbọ̀ngàn. Just a mile looks so long in those days. Torí òkè àti ìsàlẹ̀ tá a máa ń gùn, but principally Akiribọ́tọ́ àti gbọ̀ngàn. Then Akiribọ́tọ́ méjì ló tó wà. Ọ̀tọ̀ la Akiribọ́tọ́ Àgbọ́jà tí mò ń júwe, ọ̀tọ̀ la Akiribọ́tọ́ Ẹlẹ́dẹ̀. Akiribọ́tọ́ Ẹlẹ́dẹ̀ náà ò jìnnà sí gbọ̀ngàn. In fact, they are the same people moving around. So a máa ń fira wá ṣe ẹ̀yẹ. Ọ̀básò tí tọ́ka lè rí jẹ́ ẹgbẹ́. Akiribọ́tọ́ ní ilé Àgbọ́jà ló kó. Oh wow, what a childhood.
Yeah. Joe, I seem to have made it because the time zones have changed in the UK. I seem to have got everything wrong, but my daughter is about to join you shortly. I think she has already joined.
Hey?
Hello?
Hello? Our guest is in. Okay. Good evening.
Hello. Good evening. Sorry, our clocks went back today.
Without our permission.
I know. Apologies.
Very good. Welcome.
Okay, you are welcome. So we are still expecting a couple of people to join, so then we can get started. Thank you very much for coming.
Oh, of course not. Thank you very much for the kind invitation.
Thank you so much. We were confused because of the time change. Thank you so much for your patience. We are very happy that you are here with us. My name is Shola Yusuf, and with me, I have my co-presenter, Baba Otumba, that I know you know very well. Otumba Oseni. Otumba Oseni is one of the life wire of Yoruba Gbode. I want you to say hi to our guest.
Good evening, Dr. I don't want to say Dr. Olushola Oni, Dr. Oni. Thank you very much for coming. My name is Olabode Oseni, and we look forward to having a good experience with you today, especially in your area of expertise. We read a lot about you, and know that about it that I'm sure you must have superseded the level of your father. But that's the thing. That's what we all pray for. So thank you very much for coming.
Yes. Yes. Before I go forward, I am sorry. I know we all have many names. If I have an English name too that they change to Yoruba by putting you. Oh no, it's not English name, it's Arabic name. But they change it to Yoruba by putting U at the end of the T because Yoruba word does not end with consonant. So they will call me my Muslim name, Muibat. But my father will say, Muibatu. And that is why you will see Adijat will become Adijatu. Because Yoruba has to eat their head on something when they call a name. If you don't mind, can you tell me your Yoruba name? Because I know you have a Yoruba name. I don't, Georgette is so beautiful, but I want to add the Yoruba name to it because I want to show the wealth of Yoruba. You can have a child with 10 names. So can you just give me your Yoruba name that I can use? Or do you want me to add Daddy?
No, I know. It's Mogbonju Bola.
Mogbonju Bola. Ah, very rich name. Georgette Omogbonju Bola One. You are welcome. Thank you so much for coming.
Sorry to interrupt. The name Georgette, she's named after my father-in-law who died.
Oh.
As it is customary in Yoruba land, when somebody dies, it's reincarnated in the newly born. So yes. that's why. So my father-in-law was George, and since you cannot name a girl George, that's why she's Georgette.
Okay. Thank you, Dr. Georgette Omogbonju Bola One. You are welcome. We are very, very happy to welcome you to Yoruba Gbode. This topic is very, very important. Before I go to the detail of the topic, let me introduce our wise men. Yoruba Gbode, following the tradition of Yoruba, we don't do important things without having the elders that will give us support. They are the reinforce that make the program Yoruba Gbode to continue going for the past 4 or 5 years. I'm going to first introduce Baba Amoye, our head wise man, Professor Adeniran Adeboye. Baba Adeniran Adeboye is a professor of mathematics for so many years. All of our children, 90%, 95, 98, I can say 99% of our children who became doctor in the last 30 years, 35 years, they have passed through Baba one way or the other. But despite the fact that he's a professor of mathematics, Baba does not play when it comes to Yoruba culture. And that is why Baba has been with us on Yoruba Gbode every Sunday for the past 5 years. I'm very happy to introduce to you Baba Amoye Yoruba Gbode, Dr. Professor Adeniran Adeboye.
Thank you very much, Olotu. And I'm happy to welcome to this evening's event, Dr. Georgette Oni. I'm proud of you. And we are going to learn a lot from you. in your area of expertise. But we want you to also help us in some other additional way.
Okay.
Help us teach more medicine to Bashiru. because ibi tí àgbàlagbà bá wà, ibẹ̀ lọmọdé bá á dẹ̀ kọjá ẹ̀. That's what we want.
Yeah.
So I'm really just entertaining myself with almost drunken with the idea that we have you and around us, and we're going to learn and welcome.
Yeah, thank you. I mean, to corroborate, to support and corroborate what Baba Adeboye has said, you know, I used to be very dull in mathematics. I don't know. So one old man was teaching me mathematics, and I mean, I was doing very well. But I didn't know how good I was until this young girl was a woman now. This one, Arike, started teaching me mathematics, and it surpassed Baba. So anytime I was looking for a mathematics professor, I don't look for the old man. I look for Arike, the young man who knows mathematics more than anybody. Baba, do you know the person I'm talking about? Have you ever met that girl?
She teaches me too.
We are happy when our children are doing beyond and above, when they are doing great. Do you remember last week, Baba Wishe and lawyer BC Animasham? You won't even know that she's a lawyer by profession. When she was tearing into pieces all these ojuodu that she has learned from the father. We are very grateful, and we are very happy to welcome you. Oma Gbanjubola. Gbanjubola. They will shorten it. They can say Bola, they can say Gbanju, and they can also say Gbanjubola. Yeah, it's such a beautiful name. God bless the parents who gave you that name. It's a very beautiful name. Mm-hmm. So I'm also going to introduce engineer. I call him Engineer Agba. Baba Oyetunde Thomas Bankole. Baba has been a member of the wise men of Yoruba Gbode. He comes every Sunday from Canada. Every Sunday, he flies in. Engineer Bankole, you are welcome, and here is our guest.
Olotu, thank you very much. And to our presenter today, Professor Dr. Uni, I'm really proud. I've never met you, but just seeing you, I'm really proud of you, and I'm proud of your dad too. I only hope he has taught you Yoruba and not Ijebu Jesha Yoruba. No, pure Yoruba.
Yoruba Jesha.
I hope he did. If he didn't, then it looks like he hasn't done enough. But from what I can see today, and I can say he has done a lot. He has done a lot to have brought you to this place where you are. And we are very proud when we see people like you taking over from us. It's really exciting. And the topic for today is something that's dear to all of us. So we've come to learn from you. Thank you.
Thank you. So I'm going to introduce Dókítà Olopolo. We call him Dókítà Olopolo. Opolo in Yoruba it means brain, technically. Dókítà Olopolo is the professor and doctor of psychiatrist. I always have a slip tongue when I call that name. But he has always corrected me. So Dr. B. Oyefule is our Dokita Olopolo, and he has been with Yoruba Gbode since we launched on Zoom. He is one of the backbones that we rely on when we want to do anything that has to do with Yoruba tradition, medicine, health, and everything. Dokita Olopolo, here is our guest and our daughter, Georgette Gbonjubola Oni, who is going to talk to us about breast cancer today.
Thank you,
welcome
Olotu.
her.
Yeah, welcome on board, Miss Omogbonjubola Oni. We are meeting you for the first time, but we know the pedigree that you came from. So we are very proud to have you, and we are going to listen very, very carefully to you and ask some rather difficult questions if need be. But in the meantime, enjoy being here. And we all love you. We love your dad. And I personally love your grandfather because he used to give my mother contract. But you wouldn't know much about that.
Oh, wait a minute.
So anyway, welcome on board.
Okay, thank you, Doctor. Yoruba people, the way we look at breast cancer is completely different. There's so much myth and rumor that surround breast cancer. And because of that, we didn't take care of it until that person died. Yoruba people will call it Somuroro. That is the Yoruba word for it. And Yoruba didn't believe it's hereditary. They didn't believe it is a disease at all in those days. Yoruba believed that people can inflict it on you. It's like something that if you offend somebody, if you are rude to wrong person, they can make you have breast cancer. They will say once solata, ata means pepper. So when somebody, when they believe that somebody has been afflicted with breast cancer, it's like pepper that cannot be removed. We didn't have any other knowledge. And here is our own daughter who knows about it, the beginning and the end of it. I'm very happy and I'm grateful. Dr. Omogbonjubola Oni, we are going to divide this into like 3 parts. One is going to be like question that will give us the light. So another part is going to be your other part of explanation, wherever you want us to know that I didn't ask in the question. And the last one is going to be questions from the audience. Our audience has scattered all over. It's not these 12 people that we say. We have people on the YouTube. Some people don't want to be bothered. They just want to relax because after this program is going to stay on YouTube for many years. So they're sitting there. We also have some people who are listening to us on the radio. That radio goes through Philadelphia, Delaware, and stuff like that. Some people have been joining us lately from Facebook. So thank you so much. And let's start with, what is breast cancer?
Hello. Good
Hello.
evening. Hello. Hello. Thank you very much for inviting me today. So I'm a plastic surgeon actually, that went on to sort of specialize in breast oncology. So on a day-to-day basis, I deal with ladies who've got breast cancer, and I deal with removing their cancers and their reconstruction. So breast cancer basically arises from the cells within the breast. So it has to come from the breast tissue, from the ducts or from the lobules of the breast. It's basically a transformation of the cells from normal to abnormal, and there's a spectrum over which that can happen. So there is a precancerous state. So this is cells that have started to change, but they don't spread to anywhere else in the body. So this is the earliest, or stage 0, it's called. This is the earliest form. And this is the type that's usually picked up through breast screening. Okay, so you don't normally, you may not necessarily see any changes in the breast or feel any changes in the breast. So that's stage 0, precancerous change, or DCIS, ductal carcinoma in situ. It can then go into the invasive spectrum. So this is when the cells can break away and they can potentially spread to the rest of the body. So that's when you get to your stage 1s, your stage 2s, stage 3s, and stage 4s. So the stages are related to the size of the cancer and where the cancer may have gone. So as this cancer grows, it can start to spread to other parts of the body. And the route it normally takes is to go from the breast to the armpits and then elsewhere within the body. And so that's how we look at the staging. It depends on how big it is, where it is in the body. In terms of I can stop there if you want, if you've got another question.
No, go ahead. I think you are still talking about breast cancer.
So in terms of the stages, this can then direct what kind of treatments that you may require. One of the things that I emphasize is that breast cancer is actually a very treatable disease. Okay, we're getting very, very good at treating breast cancers. The survivability of cancer is actually pretty good. It's very high. Obviously, the earlier the stage that you get the cancer, the better your chances are of survival. Okay, it's also a very common disease. Okay, so statistically, about 1 in 7 women in their lifetime will develop a breast cancer. Breast cancer can also affect men, and this is something that we don't always talk about. It can also affect men. So for men, it's about 1 in 1,000. So it's a lot less the risk, but nevertheless, men also need to be breast aware.
Thank you. So at what stage can it get to that it can turn fatal, that there won't be any remedy? How far can it go? Can we put a time to it, especially the time of a discovery and the time of fatality?
So not necessarily. Not necessarily. So there's a lot of treatments now for breast cancer. So even in patients in which the disease has spread to other parts of the body, we say that we cannot cure you, but you can have treatment. And there are many women who are several years out from their diagnosis of stage 4 breast cancer. Okay, so it depends on the type of cancer, the sensitivity of the cancers to medications, and also what clinical trials are available at the time. So I run an annual breast cancer awareness conference called Let's Talk About Black Women and Breast Cancer. And we have different themes every year, but this year the theme was clinical trials, clinical research. And one of the people that helped me, so they actually put together a video, is a patient who was diagnosed with breast cancer, I think originally in like 2007. She then developed stage 4 cancer in 2017, and is still alive and well. She's been on clinical trial. She's been on I think she's on her 3rd or 4th clinical trial, but at this moment, still well. I know women who are 10 years out from their diagnosis of stage 4 breast cancer. So it is not always a death sentence. As I said, earlier it's caught, the higher your chance of cure. So that's why it's actually quite important for us to be breast aware so that we know what we're looking for to be able to present early.
Okay. So one of the things that I've seen is people with breast cancer, we heard that it will affect one breast first, and then we go to the second one. So sometimes they have to remove the breast. What effect does that have in the treatment?
So let me just correct that. So that is not a standard thing that happens. It doesn't start in one breast and then jump over to the other. That is not a usual route for a breast cancer. What can happen is you develop a breast cancer. If it's left untreated for a period of time, it can start to grow within the breast. Okay. If it can then spread to your lymph nodes, so particularly in the armpit. And then from there, it can spread to the other organs in the body, or to the bones, or to the brain. So it can spread around the body. You can develop another cancer in the other breast. You can develop what we call metastases. So it can spread to the other side, but it's not a usual route that it starts in one breast and then hops across to the other. No.
So the other breast is developing its own cancer.
It can, but again, it's not usual. So it's not very common to have cancers in both breasts. Yeah, it's not very common. What's more common is you have a cancer on one side and then it starts to spread to other parts of the body.
Okay. So can you help us to understand what are the things that can make somebody prone to breast cancer? That's very, very important.
So if we take a step back and we look at what risk factors there are. So when we look at risk factors for things, we can look at things that we can change and things that we cannot change. So if we start with things that we can change, okay, one of the biggest risk factors for developing breast cancer is being a woman. We can't change that. Is getting older. Unfortunately, we can't change that either. Okay, so being a woman, getting older, these are things. You can't change your genes, okay? But what you can do is you can find out about your family history. So we know that there are some breast cancers that are, that there's a genetic predisposition to developing them. Okay, and we now have got tests in which we can look and we can see, do you have a gene that predisposes you to developing a cancer? So having that gene, so there are a group of cancers we have linked together. So the breast, prostate, ovarian, and pancreatic cancers are linked together. If there's a strong family history of breast cancer, ovarian cancer, pancreatic cancer, prostate cancer, okay, there may be a genetic reason for why you're developing those diseases. But you need to know what your family tree is. And breast cancer, the predisposition can pass down the mother side or the father side. So it's actually important to know what both sides of the family, any conditions on both sides of the family. So talking amongst our families and talking about diagnosis, illnesses that people have, things that people have gone through is actually quite important so that you know what your risk is. And the reason why that's important is because we've got genetic tests, so we can test to see if you're a genetic mutation carrier. But it also means that you might be eligible for enhanced screening. So you might start your screening earlier than if you did not have a strong family history. So those are the non-modifiable types of things. And then you've got your modifiable things. So these modifiable factors, to be honest, these are factors that actually help you across the board with any kind of condition that you want to mention. Keeping your weight down, exercising, having a good diet, not smoking, drinking in moderation. So these are things that, you know, will help with your blood pressure. They will help with your heart risk. You know, they'll help with a multitude of things. They'll help if you're diabetic. So these are things that we can do. These are things that we can modify.
So there's a myth, or like a, you know, that I have had a long time ago, even before I came to this country. Some people will say that women who start their period early, like 13 years, or, you know, in those days, some kids may be like 14 before, but, you know, some people will start at 12. We have seen people, children who start at 11. So they always said it that for kids who start like 11, that they are prone to have a breast cancer. Is there any research that can prove that this is true?
So what we look at is your exposure to estrogen, right? So we know that it's estrogen that can be one of the factors. That's why being a woman is a factor for developing breast cancer. So it's related to estrogen. So when you start your periods young and you have menopause late, the period over which you're exposed to estrogen in your lifetime is long. So therefore, you know, and it's the same with having children. So when you have children, so the more children you have, that when you have children in the pregnancy, there's a period in which you don't really produce a lot of estrogen, right? So the more children that you have, that also means that the amount of estrogen that you're exposed to over your lifetime is reduced. So these are things that factor in. But like all things, I say, is that there is no one thing, right? It's always a combination of things, right? Because we will know lots of people who started their periods young and had menopause late that don't have a breast cancer. But if you are overweight, if you are a smoker, if you you are not doing really good exercise, if you've got a genetic predisposition, then you start to ramp up your risk of developing something.
Thank you so much. Anybody, if you are just coming in, this is Yoruba Gbode, and our special guest is Dr. Georgette Mugbojubola Oni, who is talking to us about breast cancer. And remember also, everybody, people listening on the radio, YouTube, and all over the place, remember that October has been selected as the month of awareness. Now, we talk about prevention. Are there particular food that can trigger it? At the same time, are there particular food that can keep us away from breast cancer?
So there's nothing that can trigger it as such. I think that when we talk about weight and diet, it's about a balanced diet, right? So it's about having, you know, like not heavy on the carbohydrates, good protein, fruits, vegetables, all those sorts of things, not frying everything. So reducing like kind of oily sort of, you know, the way in which food is prepared, steaming, grilling rather than frying, these sorts of things. So it's really about kind of like the calorie intake and then being balanced. And there are lots of guides and there are lots of helpful things. I think if you've got an issue with diet, speaking to a dietitian or a nutritionist can help with that. But again, these things then help with things like your blood pressure. They'll help with your diabetic control. So it's about a lifestyle modification as opposed to I'm doing this to not get breast cancer.
So, thank you. The other time we were talking about the breast, that sometimes they have to take the breast away.
Yeah.
That's cool. You know, why do they do that? Does it go to the other part of the body from the breast or what?
So what we've now seen over the years is that a combination of things is what has contributed to the improvement in outcomes for women who are diagnosed and men who are diagnosed. Okay, so it's a combination. So broadly speaking, there are 4 different types of treatment that you may have. And your treatment is packaged, right? So surgery, which is what you're talking about, is one component of your treatment package. The vast majority of women will have surgery as part of their treatment package. And when I'm talking to patients about the treatments, I break it basically down to things that are done locally to the area, so to the breast, to the armpit. And then there are things that you have which then circulate around your body. So broadly speaking, 4 things. You've got surgery, which would be to the breast or the armpit usually. You have got radiotherapy, which again is a directed treatment to the breast, chest wall area, to the lymph node basins, the regional lymph node basins. Then you've got what I call the circulating treatments. So these are things that you either take or they're injected and circulate into your bloodstream. So many of you will have heard of things like tamoxifen. These are tablets, which are specifically for women or men who've got breast cancers, which are sensitive to estrogens. It works by blocking the action of estrogen, and that circulates through the body. Then you've got your chemotherapies, but you've also got lots of other new systemic treatments that have also come out as well. So the field of systemic treatments has completely, sort of been transformed in the last decade. And we have lots of targeted treatments, which are then specific to the type of cancer you have. So we're moving into a more personalized era in the way that which we deliver breast, well, all cancer care actually, but if we look at breast, the way we deliver breast cancer care. So we don't do a one size fits all anymore. We look at things that your cancer expresses to direct and target the treatment to that. So surgery will form one part of that. Now, if we look at surgery, which is obviously what I do, if we look at the types of surgery there are, broadly speaking, again, there are two ways that you can take out a breast cancer. And it is going to depend on the size, it's going to depend on the person, it's going to depend on other factors. But if we look at it just crudely, two main ways. You can have a lumpectomy. So this is where you take out the cancer with a rim of normal breast tissue around it. This is also known as breast conservation surgery. We're trying to preserve the breast while taking out the cancer with adequate margins around it, okay? The other way is mastectomy, which is what you're describing, and that is where you take away all of the breast tissue, and within it, you then have your cancer. So the breast goes and the cancer goes with it. That's called mastectomy. If we look at it sort of if we look at like the Western world, so if we're looking at like the US, we're looking at the UK, Canada, etc., the majority of women actually have a lumpectomy. They don't have mastectomies to treat their breast cancers. So in the UK, it's about 60% will have a lumpectomy, 40% will have a mastectomy. And I think this is actually quite important for people to understand, because this is one of the things that makes people reluctant to present, is they think they're going to lose their breast. Actually, the majority of women do not lose their breast. They can have a lumpectomy. However, if you don't present early, if it gets really big, if it spreads to, other bits, so it might start in one part of the breast, it gets bigger, so it starts to take up a lot more of the breast. If it goes to the lymph nodes, it makes it harder to preserve the breast when we're getting to that kind of stage.
Thank you so much. One of the things that always scare women about the test is because the test is very painful.
Are you talking about mammogram?
Yes, the mammogram, the test to know. Is there going to be a different thing in future that is going to be less painful? That is number one question. Number two question is, how old can somebody be before you start going for the mammogram? And do you have to have somebody in your family that have had a breast cancer before you do mammogram, or is just recommended for all women? And how old must you be before you start the test?
So different countries will have different screening programs, if they have a screening program at all. So in the UK, we have a screening program. It's a national screening program. You will be invited for a mammogram from the age of 50. So between 50 and 70, you'll be invited for mammograms every 3 years. So somewhere between your 50th and 53rd birthday, you will get called, invited to have a mammogram, and then every 3 years until you're 70. You can also request one when you're over 70. So if you want one, you can request one when you're over 70. The reason that we set the age around that is because mammograms are very good at looking at breast tissue in older women. So the breast is made up of glandular tissue and fatty tissue. As you get older, you get more fatty tissue compared to glandular tissue, and it's therefore easier to see things on a mammogram. So if you are younger, so I'm thinking under 40, we don't tend to recommend mammograms. If you present under 40 and you can feel something in the breast, there are other things that we can use to be able to examine the breast. So the first thing is usually an ultrasound scan. So it's a bedside test, probe and a jelly, ultrasound scan. Other imaging modalities are things like MRI scans that we can use. So in terms of the mammogram itself, so as I've said, I run an annual conference. Last year, we were talking about around prevention and screening as part of that. And we actually showed a video of a woman having a mammogram. It took less than 5 minutes to do. Yes, it is uncomfortable, but it took less than 5 minutes to do. And then that's you done for another 3 years. I think in America, it's different. I think they're now going to start their screening from the age of 40 in America. So that's what I mean. I think depending on where you live, your screening program might be different if you have a screening program at all.
They do it every year, not 3 years. In America, it's there every year. Once you are past 45 or something like that.
Yeah, I think they've lowered it to 40 now because, again, they're trying to capture more Black women. So Black women tend to present younger with their breast cancers. So the UK data that we have, Black women, about 50% present under the age of 50, so they're not going to get picked up on this screening program. I think the US has got a higher Black population. So the American Society of Surgeons there, they've dropped their screening age, and they've specifically mentioned it's because they want to be able to capture more Black women.
Thank you. Another question that you have mentioned is about men having it. So, we women, we used to feel bad that, why? But you now mentioned that men could have it. Well, what is the ratio of men to women in this breast cancer issue?
So it's much rarer in men. So about 1 in 1,000 men get a breast cancer incidence in a lifetime. There may be a genetic reason. All men in the UK, in any case, all men that get a breast cancer will get a genetic test to see if there's a genetic reason. I think it's important for men also to be breast aware, so that to be able to examine. And again, as you get older, you're at increased risk of that. I think when we look at the data again for men and for women, if you are Black, you have a worse outcome. So again, lots to do in terms of awareness, engagement with treatment, and also engagement with research. We need to be able to figure out, why do Black people have worse outcomes from these diseases?
Thank you. So I'm going to hand over the question section to Otumba Olabode, and he's going to be the first person to ask a question. Then he can then go ahead and call other people after his own question. Otumba, Ekabo.
Thank you very much, and I want to appreciate Dr. Oni. I will allow other people to go before me, since I'm also supporting the presenter. Let's go quickly to, or if you don't mind, or maybe let me ask my question first. The one that comes to mind is the issue of genetic or generic. Is it something that you inherit it, that because your grandmother or your mother has it, and so therefore you're going to get it? Yeah. Just take note. Then the second one I want to...
just a point of correction though, it doesn't mean you're going to get it, but you're at increased risk. So actually, if you can have enhanced screening, then if you're going to do it, we can maybe pick it up earlier, and treatment may be more effective.
Okay, thank you for that. The other question is, judging the belief that how the role, I'm sorry, I'm not being vulgar here, the role breast play in the relationship, and sorry, when we are married or not. Now, what is the support expected of a man? Because we read different kind of things, even before the advent of AI, that the more you touch the breast, the better for the woman. Can you confirm which one is correct?
So I don't know about the science behind that, but what I will say is that there are men who pick up the lump in their partner's breast, right? So being part of breast aware and or double check. So sometimes when we go, oh, I think I can feel something, and then it gets double checked, and they go, yep, there's definitely something there that wasn't there before. So I think that both, people in the relationship being aware of the signs and symptoms of breast cancer is very important. In terms of relationships, obviously breast cancer is, so like I said, I trained in plastic surgery. So I trained in cancers all over the body. I've done head and neck cancers, I've done skin cancers, we do sarcoma, gynecological cancer, we do cancer reconstruction head to toe. But what I will say without a doubt is that breast cancer is one of the most emotive cancers that we have to deal with. And that is because obviously the breast has a functional component, but it also has a sexual component, relationship component, okay? So in terms, what we see is that relationships can struggle a lot through breast cancer diagnosis and breast cancer treatment. There are a lot of changes that happen physically, mentally, emotionally to the woman some of the treatments that we give do affect your hormones and your hormonal status. And so that can also play into the effects that it can have in the relationship. We've got very young women who are being diagnosed with breast cancer, and the treatments that we have to give them, even though it may be for a short period of time, nevertheless, can basically put them into a menopausal type state. So this is quite a lot for young women to have to deal with. They may not have had their family yet or completed their family yet. And some of the things that we're doing may make that difficult for them in the future. So there's a huge amount of psychological delay that happens in the treatment of breast cancer. Certainly in the UK, we have a lot of support. For instance, I'm a trustee.
Can you co-host me, please? I have no control to. Okay, go on, Dr. Oni.
So yeah, so I'm a trustee at Breast Cancer Now, which is one of the largest breast cancer charities in the UK. They have a lot of services open to patients to help support them through the journey. But there are other charities as well that we have in the UK who help in different elements of it. And then, of course, there's the things that we can offer through our own services. Probably one of the things that we would benefit more from, I would say, in the UK in our NHS services is from psychological support for patients.
Thank you very much. The final one might be a little bit not very popular. From your experience, you've been doing this for a while now. How much have you heard from anybody that prayer can also resolve can substitute what you're doing?
So we hear that, I think, in certain communities, and I do think that there are elements of this which will play into why Black women don't do as well as other races in terms of their outcomes from breast cancer. Because so one of the things that we need to emphasize is that it's not so much a supplement, but an addition, right? So these are things that can go hand in hand. There is nothing in terms of having your religious support, your prayer support, support of your faith community through this journey. In fact, for many women and men, it's invaluable. However, it is about putting them hand in hand, right? So the engagement also with healthcare professionals, medical treatments. One of the most sad things, I think, in my line of work is to see someone who has a very treatable, survivable breast cancer. You explain to them the treatment package, which for countless other women has worked very well, to get rid of their cancer, let them get on with their lives. They go away, they try alternative methods, they come back a year, 18 months later, 2 years later, having not had any medical treatment now for their breast cancer, and it's now spread. And we've gone from something that was treatable, curable, to something that is not, okay? And so try to treat somebody who's in a stage 4 cancer is not the same as treating someone who was in a stage 1 cancer. Yeah. So it can be a life-shortening thing when you decide to engage with healthcare professionals and modern medicine. And I always say there's no reason why they can't go hand in hand. There's no reason why they can't.
Okay. Thank you very much, Dr. Oni. Let me now go to Baba Bankole, one of the major stakeholder here. Baba Bankole, your question.
Yeah, thank you very much, Otumba. Dr. Oni, thank you very much. Even though I have to be very, very attentive because of your Queen's accent. Here in America, we don't get exposed to that heavy dose of Queen's accent. So in order to catch every word you are uttering, I have to be very attentive. I don't have much problem with your dad because when he talks, I know where he's going. So, my question, with the present day diet and with our foods being spiced with GMO and everything we hear, what chance do women, well, I'll say women, what chance do they stand when it comes to breast cancer and even other cancers with men? And so that's one. You said something about estrogen and childbirth. I didn't catch that very well. Remember, I said I had some problems with. So, did you say that the more children you have, because maybe I don't know whether you've the more children you have, the less disposed you are towards having breast cancer? Is that so?
So it's about exposure to estrogen. So the more pregnancies, the more breastfeeding, it reduces your overall lifetime exposure to estrogen, because during those periods, you're not producing as much estrogen. So we all produce estrogen, including men, by the way. We all produce estrogen. But so when we look at the risk, the relative risk, it's about the total lifetime exposure of. So things like childbirth, breastfeeding, starting your periods late, finishing them early, so going through menopause early, these all reduce your lifetime exposure to estrogen.
Oh, that's good. And then, well, remember there was a question before this, but my number 3 question is, you mentioned systemic. I know when I go for treatment, I see they say systemic. So there's the systemic that. What is systemic in cancer treatment? Then my last question is, what is it in the black gene that makes that predispose us to cancer so highly than other races? What is it in our gene?
I'm gonna respond to those in reverse. So we actually have low incidences of cancer in Black people. This is the issue. So actually, Black women get breast cancer at a lower rate than other women. The problem is we don't survive it as well as other women. Okay. And we're not really sure why, is the honest answer. We do know that Black women tend to get the triple negative variant of breast cancer more than other races. Okay, so about 1 in 3 Black women get triple negative, whereas about 1 in 5, 1 in 10 of other races. So we tend to get triple negative more. Triple negative is a disease that tends to affect younger women. So we tend to get breast cancer younger. Triple negative historically was one of those diseases in which we didn't have a lot of targeted treatment. That's changing, but we didn't. So that probably plays in. But the fact is, we don't have a lot of research on Black women in breast cancer. And so now that there's developing an interest now as to why is there this group of women who are not doing so well, research is now starting to happen. So there's a major research program happening now, which is looking across America, UK, and Africa. And it's looking at breast cancer in Black people, but also looking at prostate as well. So they're looking across the 3 continents for breast and prostate. So there's going to be more research coming through, which may help to answer some of that. Then the other question you asked was around genetic predisposition, wasn't it? So again, I think that, again, triple negative is one of those breast cancers that tends to have a higher genetic predisposition than the others. So overall, if you look at breast cancers, a genetic reason for why you've developed it, it's only about 1 in 10, 1 in 8 people. So it's not actually very high on the list of things that push you into that breast cancer category. However, obviously triple negative is one in which you're more likely to have a genetic predisposition. So the likelihood is there are actually quite a lot of Black people that have got a genetic predisposition, but we just don't know, because either you don't get tested, you don't know your family history. And so, you're not going to get tested and you're not going to understand your risk. So talking amongst families is actually quite important. And I emphasize this quite a lot, is that we've all got uncles, aunts, sisters, brothers that have died of something, but no one's really quite sure what it is. It's very hard, therefore, for other people in the family to be able to know what their risk is. So talking about it, and that's why things like this are really important, is, to talk about it, to normalize those conversations amongst ourselves, amongst our families, amongst our friends, so that we can all try to start to help reduce our own risk. And then I think
thank you very much.
Well, no, sir. I still have I asked what is systemic and with GMO and the present diet.
All right, thank you.
Yeah, so systemic, it basically means in the circulation. So it goes through your bloodstream, right? So tablets go systemically. When they give you like a drip through your vein, that goes systemically. So anything that basically can get into your bloodstream is what we call systemic, because it goes all around.
Okay, that explains it.
Yeah.
And the diet with
I mean, obviously
GMO.
fresh Yeah, fresh foods and things like that are always going to be, you know, best. But I think what we don't understand is the financial implications of these things, right? It's expensive to eat healthy, right? You know, it's much easier to eat junk and that because for a lot of people it's cheaper, it's easier. You're getting stuff on the run. We live in a very fast food, you know, kind of era now. So it does take some re-education and some learning, and we're all guilty of it, you know. But I think just trying to be really good about fresh fruit, fresh vegetables, you know, reduce the carb intake, reduce the amount of things that we're frying, try to steam, try to grill. All of these things are going to be better and healthier for you.
Thank you.
Thank you very much, thank you, Dr. Oni. Well, I have a surprise for you. I have an uncle in the house. I'm sure. Wale Oni, let's your...
Thank you.
Yeah.
Thank you very much. I think you can hear me.
Yes. Hello, Uncle Billy.
Hello, Georgette. How are you?
Thank you.
Thank you for giving us your esteemed knowledge about breast cancer. I have 3 questions for you. Okay. My first question is, in Nigeria, and I know you've done some work in Nigeria, I just want to know what's the incidence of breast cancer in Nigeria? Is it comparable to that of the UK? For those figures you gave out there, and the treatments, because I've seen some very horrible pictures of women with breast cancer that's been left untreated, and people have died in very, very bad agony. And I just want to know if you have anything you can share with us in terms of the incidence compared to the UK.
So actually, no, I'm not entirely sure. What I do know, like globally, is that Black women have a lower incidence than other ethnicities for breast cancer. One of the, I think, so the thing that I was at before this was actually a premiere of a documentary that had been filmed specifically focusing on Black women and breast cancer. And it was filmed across the 3 continents. So Nigeria was one of the places they went to, South Africa, the UK, and America. And I think one of the sort of striking figures that came out of that is that even though there is a very low incidence, and I think they quoted about 8% in Nigeria, the mortality was very high. So like 12%, so much higher than you would expect given the low incidence. The mortality from breast cancer, so that means you will die of your breast cancer, was much higher than you would expect. And part of that is going to be because of the treatment options available. And obviously some of that is going to be to do with late presentation, not engaging with those treatment options that are available. So if you remember right at the beginning, we talked about the different types of treatment modalities. So these are surgery, radiotherapy, chemotherapies, tablet therapies. Radiotherapy, there's very poor access to radiotherapy in what they call them low middle income countries, of which most countries in sub-Saharan Africa come into that bracket. Radiotherapy is very, very limited availability, okay? And when we look at maps which overlay like radiotherapy availability with mortality, they're pretty close. So access to that, so access to specialists that can deliver treatment, access to drugs in that treatment, and access to people that can perform surgeries. So you need to be able to get to a hospital, you might need to get to a specialized center. These are big countries, vast lands. There's going to be limited access to these things. And then there's, even if you could access it, can you afford it? There's a huge financial toxicity, financial burden that goes along with having a cancer diagnosis. For some women, you're having treatments for over a year, if not longer. And so it's trips to hospital, it's paying for treatments, it's paying for drugs, it's paying for any investigations. These things quickly ramp up. So again, if we look at the UK, technically we get free treatment right at the point of entry, but still we know that Black women don't do as well. So there is something about the access, there's something about the availability, but there's also something about the inherent aspects of the disease in Black women that we need to get a better handle on. But definitely, you know, things are worse in Nigeria in terms of outcomes. And I think part of that is to do with being able to access, part of that's to do with availability of things that we now know form part of your treatment package to improve your outcome. And part of it's to do with engagement and the financial toxicity of having a cancer diagnosis.
Thank you. My other question is that if you've done like a mastectomy, do you have to remove both breasts, and do you do reconstruction breast after the mastectomy has been performed?
So again, one thing I want to emphasize is that a mastectomy is not always the surgery that you're going to have. And the reason that I emphasize that is because this is one of the reasons why women do not want to present, is because they don't want to lose their breast. If you present earlier, if your cancer is small, the likelihood is you will not lose your breast. You will have a breast conserving operation. Now, if you do have to have a mastectomy, certainly in the UK, it is one of our standards, our guidelines, is that all women should be offered a reconstruction. And reconstructions can occur at the time that you have your mastectomy. That's called an immediate reconstruction, or you can have it in a delayed fashion. So you can have your mastectomy, you are flat for a period of time, you might be having other treatments and things, and when they're all completed, you can then come back and have a reconstruction. It can be immediate or it can be delayed. We know that not every woman will take up a reconstruction, and that's fine. This is a choice that women can have. If you do not have a reconstruction, again, we know that there are lots of women that are happy just being flat, but there are some that want to have a breast form. And that's when external prosthetics can be useful. So you can have a breast form that can sit in a bra, can sit in a swimming costume, so that you can have a breast shape. But when you take off your clothes, you take off your swimming costume, you are flat on that side. So that's an external prosthesis. In terms of reconstruction, there are different ways in which we can reconstruct. You can have a partial reconstruction, you can have a total reconstruction. Total reconstruction can be made up of parts of you. So one of the operations that I do is that I take tissues, for example, from the tummy, and I can rebuild a breast. That's called a diet flap. So you can use your own tissue to reconstruct, or the commonest form of reconstruction in the world is implant-based reconstruction. So we take a silicone implant and we reconstruct the breast using that.
Thank you very much. That's it for me. Thank you. Thanks, Dr. Nuba.
Thank you very much. Now, I want to call on Dr. B. Uyefule. Dr. Oyebi.
Thank you, Otumba. Yes, I'm on right now. Yes, thank you very much, Dr. Uni. And it was a very, very good lecture, went straight to the point. I had two questions to ask you that you did answer the first of those questions about the fact that breast cancer is not limited only to women. Men do have it, and I think you mentioned 1 in 1,000. So you did answer that. I heard that very well. But the next question is that it has to do with breast cancer, either male or female. The fact that breast cancer itself is not one single illness, it's not of one single pathology. You know, our people tend to think in terms of cancer, no cancer. And could you please address the fact that breast cancer could be malignant, it could be non-malignant, it could be benign, and that even the real bad malignant ones come in different forms, different pathophysiology, different virulence, and all in all, it's not one single unitary illness. Could you address that, please?
Okay, so breast cancer, by definition, is always malignant. Okay, so if you have a breast cancer, it is a form of malignancy. Now, for a lot of people that present with breast lumps, very rarely is a breast cancer. So if we look at what we call our symptomatic clinics, so this is clinics in which people can feel something, they come, we assess them. The conversion rate it can be anywhere between 1 in 17 patients to 1 in, I think we got as good as 1 in 7 in COVID. So for the vast majority of people that are coming to a symptomatic breast clinic, they do not have a breast cancer. There are lots of things that can give you lumps in the breast. And breasts, to be honest, are quite lumpy generally, which is why, again, we tell women it's very important that you know your breasts. Examine your breasts every month around the same time. Examine your breasts so that you know what's normal for you. And if something changes, you then know that you need to go and get that checked out. So the vast majority of things, even from being called back from your screening, they are not cancers. There are some things that we know can predispose you to developing a cancer in the future. And again, if we find those, we may say, you know what, you should have enhanced screening. For a lot of these women, we are not doing surgery. We're just telling them, look, you can have enhanced screening. We'll keep an eye on things. So in terms of the ones in which we do find something, you can have, we call it a pre-malignant stage, but essentially these are abnormal cells, which if we just leave them alone, they are going to turn into cancers that can spread around the body. So again, there are lots of cancers that we know about this pre-malignant stage. We treat that and essentially you are cured. You should not go on to get something that can spread around the body. So in breast cancer, that's DCIS or LCIS. So these are the in situ carcinomas, all right? And these are the ones that are often picked up in screening because you don't feel a lump, you don't see any changes. So these are ones we see on mammogram and we go, okay, you've got this area on mammogram, we've taken some tissue and we've looked at it under the microscope, it's pre-malignant, we think we need to remove it because if we don't remove it, it's going to become something that can spread. And then there are the malignant ones. Now, there are different types of breast cancers. And we look at things that the cancer expresses to be able to kind of categorize them. The majority of breast cancers are estrogen receptor positive. That means they are sensitive to the circulating estrogen. So about 70% of breast cancers are that. Then there's the 10–15% that are the triple negative. So they don't really produce any receptors. And that's what has made them quite challenging to treat because they don't really have things that we can target as such. And then there are some what we call HER2 positive cancers, and we do have targeted treatments for HER2 positive cancers. So women can have a combination of those. They can be triple negative. They can be, estrogen receptor positive and HER2 positive. They can be estrogen receptor negative and HER2 positive. So you can have a combination of these, which is why we're a bit more personalized and a bit more targeted in the way we treat your cancer. We want to know what does it express so that we can target the treatments to that. Yeah, and I think that's really the crux of why we are getting much better at treating and curing people of their breast cancers.
Thank you.
Dr. Yefule, are you done? Are you okay with any more questions?
Yes, I'm okay. No more questions.
Okay. I want to thank you very much, Dr. Oni. I also want to say again, we still have some more minutes to play with. So if anybody still have anything to ask Dr. Oni, please raise up your hand, and then she's here. And I also again want to say we've had many presenters coming to pitch and coming to tell us about their professions. They all done very well. You also you come into the book of well present. We want to appreciate. But Professor Adiboye, you have a question for our guest. Go on, sir. Mr. Rainza. Let me see if I can unmute you.
Yeah, I think I'm unmuted now.
Yes, thank you very much, sir.
Yeah.
Go on, sir.
Yes, thank you very much, Dr. Oni. I see that some of my friends have a lot to learn from you. So do I. First of all, you alerted us to the fact that even if it's less frequent, breast cancer also occurs in men. But while you were saying that, you also hinted at prostate cancer in women. Is that the skin, the SKENE?
No.
Or what is that? What is
No. So prostate cancer in men, not women. So prostate cancer in men, there's a gene called the BRCA gene. So this is the breast cancer gene. And it's implicated in breast, prostate, ovarian, and pancreatic cancers. So if you've got very strong family history of like prostate cancers, ovarian cancers, you may also be at risk of developing breast cancers. So we can do a genetic test that can then tell us if you're a gene carrier, a gene mutation carrier. And then if you are, then there are some risk reduction strategies we can have to try and stop you from developing the cancer. So if you are a BRCA mutation carrier, you've got an 80% chance for BRCA1, you've got an 80% chance of developing a breast cancer over your lifetime. If you're BRCA2, you've got 60% chance of developing a breast cancer. So this is much higher than the background population. But we have strategies that we have which range from surgery to tablet therapies to try and reduce your risk.
So whatever, either I'm confused or something. There is a suggestion that there's some form of prostate cancer in women. And I wanted to know what that's all about.
Not that I know of.
Okay.
Women
prostate or something of that nature.
Women
and
don't have prostate.
They also have a spelling for the cancer, Skene.
I'm not familiar with that. I'm not sure. As far as I know, women do not have prostate glands and they cannot develop prostate cancer, but you can have a genetic link.
So it may be some kind of abuse of language or something like that. The other question, the other thing I have is not so much a question for, well, the question that one more question that I have for you, since you have more than one doctor in the family, can we get an idea of what is in our fundamental living style? Not the imported style, the living style, what we are eating, what we are doing before westernization got to us. What aspect of our lifestyle in Nigeria, in general, Yoruba land in particular, aids or works against us as far as cancer in general and breast cancer in particular?
So I think one of the things that I've heard about this, and I'm not professing to be an expert, but one of the things I've heard is that actually, because health is generally getting better, illnesses that would have killed us off before are not illnesses that are killing us now, right? So because the general standard of living is better, you now have time to develop, because cancer tends to develop as you get older. And obviously, life expectancy is improving, healthcare generally improving. So one of the theories that I've heard is actually because all of these sort of endemic type illnesses are not killing people anymore, they can then go on later on in life to develop cancers. We know that there are some, so I mean, again, I'm not an expert in this, but things like bowel cancers and stuff can be related to diet and carcinogen exposure. Some of the like the gastrointestinal tract, so like sort of your gullet, your esophagus, things like that. These can be related to things that you've eaten. These can be related to smoking. Some of the head and neck cancers can be related to viruses. So we are getting better at understanding what can potentiate cancers. But in terms of things that are specific to Yoruba land and development of breast cancer, I couldn't say. I think that one of the things that I tend to emphasize is what can you do now to try to reduce your risk.
Mm-hmm. Okay. Well, that's the end of my question. It's just that I want to add something for the audience.
Okay, sir.
The difference between the relationship between man and woman in earlier times was not nearly as dramatized or romantic as it is today. And yet, as Dr. Onias just said, we may be living longer and therefore have exposure or more intense exposure to problems that we didn't have before. What are we learning socially as a people about our relationship with our spouses that will allow us to be assets in detection and cure of whatever cancer affects the person. Prostate for men, breast for women, and so many. What are we doing socially? What kind of social education are we allowing ourselves that will allow us to be assets in the management of those diseases?
Yeah, that's a very important point, I think.
I mean, I may be asking the doctor, but I'm also asking each one of us to think about it, because she said that some men are able to help detect cancer in their spouses or in their partners.
Yeah, by touching.
By touching. How much were we doing before? How much are we not doing now? And what does that mean? I mean, as we change whether we like it or not, Westernization is impacting our lifestyle. Sometimes for positive, sometimes for negative. What is the level of our awareness? I'm asking this as a general question, not for the doctor. She wouldn't know necessarily what all of us do, but I think we have to worry about that.
I missed something. So what about touching? I didn't get that part. Even
I
though I have
the question before, but you can dwell on it again, no problem.
Yeah, no, it's about detection. So if you feel a lump, so sometimes partners feel a lump when you might not have done. Sometimes you feel something, but you're not sure, and partners double check and they go, yep, that definitely was not there before. So it's about the support that your partner gives. And I think it's important not just in detection, but it's support through treatment and after, because the person will have changed as a result of what they have gone through in their cancer diagnosis and their cancer treatment. So it's about support at diagnosis, support during treatment. And for some women, treatment can be for years, not just months, and after, because things will change. Okay. And it has a toll on families, particularly when you get it when you're young, and you might have your young family, or you might not have your family yet. You might be newly married. You know, I've had women as young as 19 in my conference who have had a breast cancer diagnosis. So, you know, I think it's very important, I think, for us to be breast aware, but also to think about the support that we give people that are diagnosed and are going through cancer treatment, so they don't feel isolated. They don't feel, you know, some of the things that we hear is that, you know, they've been cursed. It's something they've brought upon themselves. They don't want to talk about it because it has effects on their family and about, you know, the way other people will treat members of their family. The viewing of the documentary that I just went to see, it was dedicated. So the director of that film had a very close friend that died of breast cancer, and he was the last person that she spoke to before she passed away. And the mother of that person said to him clearly, do not mention she had breast cancer at the funeral. We do not want people knowing that that is what killed her. So, you know, it can be a very isolating diagnosis. It can ruin marriages. It can split up families.
Thank you very much, Dr. Oni. I quickly want to go back to
that question. I have a question.
Oh, okay. Yeah,
so my question, I don't know whether it is it can be termed medical or political, but Dr. Oni, have you been able to I mean, you're in the course of your study, have you been able to figure it out how or find out why is it that Black women were prone to many diseases? Apart from poverty, is there any other reason, like some medical, some genetic, anything that make life so difficult for us that we have to, all the diseases in the world, it has to be like more Black than white?
So it's not that we're more prone to diseases. I think our outcomes are not as good from diseases. For many diseases, actually, we have lower incidences. We don't get it as often. It's just that when we do get it, we don't do so well. And there's a number of cancers that is the case. It's going to be for a multitude of factors. So, the one we really don't have a handle on is whether biology is different. But we know that there are social factors that can influence, there are economic factors that can influence, there are cultural factors that influence, there are religious factors that influence. There's interaction with healthcare can influence, there's systemic racism issues that can influence. So there's a whole bunch of things that can influence outcome. And we cannot control all of them, but we can control certain things. So we can control things that we do to reduce our risk. We can control the way that we support people that have a diagnosis. We can control how we discuss about cancer diagnosis and about illnesses within our families. We can control those. We can control how we use things that we know influence people's lives. So we've talked about religion. We know that people have a lot of faith. We know that church is very central to a lot of families and to community life. So knowing that you have positive support from these institutions is also quite important as well. So there's things that we can control and there are things that we cannot.
Thank you very much.
Thank you.
Can we go to Baba Bankole again before I ask my own question? Baba Bankole?
Yeah, thank you very much, Dr. Oni. We are really enjoying your presentation, and it's a lot of an eye-opener to some of us. So I just want to ask, the last question, which was asked by Yeye Yusuf, about why is it that Black women get everything thrown at them? I would think that inequities in healthcare also contribute to the problems of not only Black women, but Blacks as a whole. Because here in Canada, that's one thing we are advocating against, or advocating for, the breaking the barriers between what we get and what the white people get. So my question is about silicone implant. Some years ago, there were so many reports. Sorry?
No. She needs, I mean,
Atibo, Baba. Sorry, Dr. Oni. So what I'm asking is regarding silicone leakage. I mean, some years back, I don't know, maybe about 10, 15 years back, there was a lot of report about leakages. In your own view, has there been improvement? I mean, I know technology has improved. So many things have been modified and improved. So when it comes to silicone implant, what do you think? Is this safer now than it was 15 years ago?
Yeah, so implant-based reconstruction is safe. There's been unfortunately, there's been lots of implant scandals. So implants are used not just for reconstruction, they're also used for cosmetic augmentation. So if a woman just wants bigger breasts, they can have implant-based augmentation. So there's been lots of scandals over the years with implants. There's been queries as to whether they actually increase your risk of getting cancer. We know that that's not true. There's been scandals around the way that they've been manufactured, and so there's regulations about that. There is some diseases that we know that arise from capsules that form around implants, and so those types of implants have been withdrawn from the market. So periodically there are things that kind of raise their heads around implants, but overall, in terms, is it a safe form of reconstruction? Yes, it is. Vast majority of women that have a reconstruction will have an implant-based reconstruction. What I do tell women, it's not a permanent form of reconstruction. So if you have an implant-based reconstruction, you will come to revision because it's a foreign body. Your body will go, it does not belong to me. It will put a wall around it. And with time, you will need that reconstruction revising. So you can imagine if you're in your 30s, your 40s, and you've had your cancer, you've had an implant-based reconstruction, you know that over your lifetime, you are going to have multiple operations because you've got an implant-based reconstruction. That being said, if you have an implant-based reconstruction, it may be that later on, when you are having a revision, you swap to your own tissue. So just because you start off with an implant-based reconstruction does not mean that you have to continue with an implant-based reconstruction. You may decide to opt for own tissue. There's a lot of reasons for why women have implant-based reconstruction versus their own tissue reconstruction. And those reasons may change as you get older and life changes around you.
Thank you very much. I got an alarm, and I need to work on that. Now, Uncle, you want to ask another question before we round up? Uncle Waleoni?
Yes, I do. I meant to ask this earlier, but I forgot. George, I just want to know, George, how do you actually diagnose when it presents for the first time, or there's there's an idea that they might have the cancer? How do you actually diagnose it? Is it through a biopsy or blood test, or how is it done?
So there's two main routes to which patients end up with a diagnosis of breast cancer. So they either go on what we call a symptomatic route. So they feel something, there's a change, and that's what they present to the doctor with, or it's through screening, okay? So by and large, screening, we're hoping we're picking up people in a very early stage before they can feel something, okay? Symptomatic route, so again, symptomatic route, what we know in the UK is that actually, if you're an ethnic minority, you're more likely to present in extremis. So that means you're presenting through A&E. We should not be picking up cancer diagnosis through the emergency department, okay? So again, this is about access, this is about understanding signs and symptoms to know how early to present if you see changes in your body. But also, someone else mentioned it, it's important that medical professionals also understand that Black women can get breast cancer earlier, okay, than is expected. And so therefore, when they're coming and they're saying they've got a lump, it needs to be taken seriously and it needs to be investigated. So in terms of how we investigate, so if we talk about the symptomatic route, how we investigate is by something called triple assessment. So this is what we do in the UK, it's by triple assessment. You will see a clinician who will take a history, who will examine you, okay? You will then have some sort of investigation. That's the second step. So whether that's an ultrasound, a mammogram, usually it's ultrasound, mammogram, maybe both is your investigation. And then if they see something on those investigations, you may then have a biopsy. So we're actually obtaining a little bit of tissue from what they can see to look at it under the microscope to see, is this a breast cancer? So triple assessment. So this is the symptomatic route. Through screening, you're well, you've not really noticed anything, but you have a mammogram, they see something on that mammogram, they call you back. And then they may need to do further images, they may need to repeat the mammogram, they may do an ultrasound, and then again, biopsy.
Thank you.
Thank you very much. Alagba, please, we have a budget with time. We don't have much time. It has to be a quick question, and I expect Dr. Oni to give a quick answer. You're going to be the last one before we say a vote of thanks. Alagba, Prince, oh yeah, quickly. Prince Tuji?
Muted.
Thank you so much. I appreciate the beauty of today's presentation. Very, very touchy for me because having to be, have a sister that was a victim. I don't know whether my question can never help her because she passed after carrying hers for 12 years. And good thing I was in Nigeria to see her 3 months or 4 months before she finally passed. My question is, she has a mastectomy for the 2 breasts. You know, I was thinking after she removed both breasts, she will not have to go through these cancerous things again. Is there any reason for this to resurface again after, you know, losing her 2 breasts? Maybe within the period that she had cancer.
Thank you. Dr. Oni?
Yeah, so I'm sorry to hear about your sister. I think that this is one of the things that's actually quite important to understand. A mastectomy does not stop you from getting a recurrence. What it does do is reduce your risk of having further disease in the breast because the breasts have gone. But you can still get disease that comes back in the skin near the mastectomy, in your armpits, or anywhere else in the body. That's called recurrence. So recurrence can be local, regional, or distant. So somewhere else, distant away from the breast and the armpit. So there are certain, and again, this is about now that we know more about the different types of breast cancer, we know that triple negative is the one we talk about a lot because we know that Black women tend to get it, younger women tend to get it. But with triple negative, by and large, if you are 5 years out from that, then you're unlikely to get a recurrence. We know it's got very good prognosis after about 5 years. With estrogen receptor positive breast cancer, bear in mind this is the most commonest type that women will have. There is a year-on-year risk of disease coming back. It's low, but there is a year-on-year risk. So now I'm seeing ladies who might be 20, 30 years after their original breast cancer that are coming back with a recurrence or another breast cancer. Now, again, for a lot of those women, we treat them and then that's done. But we will see women that come back and the disease has come back elsewhere in the body and it's not something that we can cure.
Thank you.
Because
of time, just a quick one. This might be a little bit more political. I understand that you do a lot of outreach in Africa, especially in Nigeria. What will you say in terms of anybody? How much do you think governance has brought to your support in terms of where you can just rely on nearby clinics or hospitals and so on? What will you say? Do you think they're doing 1 out of 10?
I mean, I couldn't judge. I don't think that I've got enough exposure to healthcare systems. What I do know is that there is a lot of collaborative types of working. There are lots of people who are trying to improve like the structure, the way in which services are developed in terms of, and then tailoring it to the local population, because what works in the UK doesn't, it's not exactly what we do in the US. It may not be what works in Nigeria, for instance. So I think it's important that, we use the science, but you also have to look at the culture. You have to look at the structures that you're working within to see what you can do. And there's lots of things that we have not adopted yet. And it might be that actually, I always say that it may be that there are steps that we jump over in countries in Africa, for instance, because actually they don't need to go through what we've gone through to get to the next step, almost, if that makes sense. And it might be that there are technologies and things that we just go straight to using in African society, for instance, that we've had to go through different iterations to get to, just because there's no point going, doing the retro steps, as it were. So, I think that like a lot of things, it's very hard for well-meaning individuals to make big differences. They may make big differences locally, but not necessarily on a national or even a regional level. So it does take a lot of structure and a lot of buy-in, political structure, political buy-in, governance, government, institutions in order to see a big shift change. And obviously one of the things that's happened in the UK is that it's actually a very structured way in which care is delivered. We have very specific guidelines around treatment, around medication, around what you do and when. It's a very structured sort of pathway in that respect. And the aim of that is to try and give uniform outcomes for people.
Thank you very, very much. Let's do.
Thank you. Thank you. Thank you very, very much. Yoruba will sing Ẹ̀bùn lọ́mọ, Ọlọ́run jẹ́ á bí, tá a bá bí, Ọlọ́run jẹ́ ó gbọ́n. I'm very, very happy and I'm grateful to Dr. Mogbojubola Oni for the fact that we are able to gain, we are able to learn. And I also thank her sincerely that she takes the time to come. I always appreciate our guests when they come on Yoruba Gbode, because it is a Sunday when you are supposed to be resting and prepare for the next day. Dr. Oni, if there is something that you can tell this crowd, our people, what will be the last word, the advice that you can give to our people? Thank you.
So I would definitely say know about risk factors that you can influence. So modifiable risk factors. So we talked about them a lot: diet, exercise, not smoking, alcohol moderation. Talk amongst families. It's really important to know, to be able to talk about it amongst families, and support, look after each other, help each other. You know, these can be very isolating diagnoses. So knowing that there's like a community that is around you to support you, I think is all important. And then the other thing is, like, faith and medicine can go hand in hand. We're not opposing each other. We want to work together. We want to amplify each other, right? So that, you know, the benefits are better because we're working together.
Thank you so much. Thank you. We are grateful. We're going to call you again because our people say when an orange is sweet, you don't stop at one. So we are going to, and the fact that you are ours gives us the happiness and the courage. Thank you so much. May Almighty God continue to be with you. We are grateful. Lórúkọ Odùduwà, mo dúpẹ́. Thank you.
Thank you very much. We all appreciate you. Thank you very much.
I know.
So, well, we finish early today, thank God. Next week is going to be a panel discussion, and is going to home, sweet home. Home, sweet home. Please tell other people so we can meet. As usual, I will work very hard to make sure that the promo get out.
Lots of questions. Actually, that's why I
get the promo. When you get the promo, please don't hold it. Let other people share. Let other people enjoy and benefit from this knowledge. Thank you so much. And I'm also taking this opportunity. Ẹ̀yin onínú dídùn ọlọ́rẹ, ẹ má gbàgbé Yoruba Gbode, Shengi, and we are still borrowing and Yalegbeni on this platform, so we can go out every week. Please help us so we can help others, so we can continue this program. Ètò yìí ò gbọ́dọ̀ kú o. Torí pé awo ò gbọ́dọ̀ tójú ọ̀gbẹ̀rì ìdáfánù. Bẹ́ẹ̀ ni. Thank you so much. I'm taking this opportunity to thank Baba Amoye and Amoye Thomas Bankole àti Amoye Dr. Oyefule. Ọlọ́run aṣọ yín dé láyọ̀ àti àlàáfíà. I'm grateful to our co-partner, Ọ̀túnba co-partner. Ìkànnì wọn múnú méjèèjì. Ẹ rí pé ìbò wọn ọbọ sórí tautology, èmi ò gbé ìbò. So I'm grateful to my co-presenter for his help always. Thank you so very much. I'm grateful to Ba Shegun. I'm very grateful to Ba Shegun. Àwọn ni wọ́n ṣe ọbẹ̀ tó dùn tá a fi jẹ níbẹ̀. Ọlọ́run á jẹ́ kí ẹ jèrè àwọn ọmọ náà láyọ̀ láṣẹ Olúwa. Ẹ máa jèrè.
Àmín. Thank you very much.
So ní a fi àdàgbà ètò irọ́ sí. Ẹ má gbàgbé láti ran Yorùbá Gbòde lọ́wọ́, ẹ̀yin ọmọ ẹni. Ẹ má gbàgbé pé mo ní ìwé wà. Ẹ wò á kàn jùlẹ̀ ni. Ìwé D.O. Fagunwa gbogbo apá mẹ́fẹ̀ẹ̀fà tó ṣe, ẹ lè gbà á. It's just like fẹ́lẹ̀ torí a fẹ́ kí gbogbo àwọn èèyàn ní shelf. Ìwé aláwìyé apá kìíní títí di apá kẹfà, ẹ lè gbà á. Mo mọ̀ pé alàgbà Wọlé òní bílù wọn ṣe jìnnà tó, wọ́n ọ̀dà ìwé wọn sì ní. Ẹ̀yin náà jọ wọ́n ká ẹ ṣe bẹ́ẹ̀. Ó jẹ́ bó ṣe ní òun jẹ. Ṣọlá Yusuf ní orúkọ mi, obìnrin gbọ̀ngbọ̀ngbọ̀n bí ẹni tẹ̀pá òjé. Àìtó ní bá gbé ká má tó ní bá wí. Ọmọ wọn nílé Olú Òkun nìbàdàn nílé Olúyọ̀lé. Ọjọ́ mẹ́jọ ni a tún pàdé bí ẹlẹ́mìí ò bá gbà. Mo ń fi àsìkò yìí kí ìdílé lọ́ọ̀yà Tinú Akínṣọlá wọ́n kú ìpalẹ̀mọ́ ọmọ wa dókítà Tolúlọpẹ́ ọmọ Akínṣọlá ọjọ́ àkòláyọ̀ pẹ̀lú ògo Ọlọ́run. Ìpàdé di ilé Ìbàdàn níbi tí a ti jẹ gbẹ̀gìrì àti àmàlà ní ọjọ́ Jímọ̀. Ẹ̀yin tẹ́ ẹ̀ bá wá ẹ fọkànbalẹ̀ máa kó àmàlà.
Gbẹ̀gìrì àti láfún ni o, kì í ṣe gbẹ̀gìrì àtàmàlà o.
Ó dáa ẹ̀yin tẹ́ ẹ̀ bá wá lè wá mo jẹ́jẹ́ fún yín pé màá gbé àmàlà tì yín wá ńjọ́ mẹ́jọ. Títí di ọjọ́ mẹ́jọ, Ṣọlá Yusuf ní orúkọ mi. Èmi ní obìnrin gbọ̀ngbọ̀ngbọ̀n bí ẹni tẹ̀pá òjé. Àìtóní bá gbé ká má tóní bá wí. Ọmọ wọn nílé Olú Òkun ní Ìbàdàn nílé Olúyọ̀lé. Ẹni tó fúnni lówó kò fẹ́ kí ebi ó pani, ẹni tó fúnni nímọ̀ kò fẹ́ ká rìn lókun àìnímọ̀, ẹni tó fúnni lọ́mọ kò fẹ́ kí á jàjẹrun bí iṣu. Mo dúpẹ́ lọ́wọ́ yèyé mi Egbinọlá Adékúnbí Àtúnwá Ẹ̀dùn ló kọ́ mi láṣà mo jèrè àṣà. Ìrè ní mògùn ará àlágbẹ̀dẹ ọmọ awúrin túnrin rọ ibikíbi tó o bá wà ilẹ̀ rí o. Ẹ ṣeun wo ó di kọ̀.
Ó di dọ̀ngọ̀rọ̀.
Bàbá Bankole bẹ́ẹ̀ ṣe bàbá Bankole sọ pé àwọn fẹ́ máa ṣe ẹ jẹ́ ká fún wọn ní opportunity kan máa bá wa ṣe. Ẹ ṣe o. Happy weekend everybody. God bless you.